pediatric patellofemoral pain. So just a little background with this first. My final clinical was at Benchmark Physical Therapy in Ooltewah, Tennessee, and it was primarily an outpatient orthopedic affiliation, but I chose a pediatric patient just because that's a population that I'm particularly passionate about. So the purpose of this was to apply the ICF framework to guide clinical reasoning for a patient who provided a unique learning experience. So let's go ahead and meet my patient. My patient was a 15-year-old male. He's a 10th grade student, a football player, and soccer player. Coming into the initial physical therapy evaluation, he identified his chief complaint as right anterior knee pain, which began approximately 2 weeks prior to the initial eval. When giving him the 0 to 10 pain scale, 10 being the most extreme, he identified that his pain had reached a 7 out of 10. At the initial eval, he identified it as 6 out of 10, and that was with activity. The functional limitations that he identified was his ability to run and fully participate in soccer practice, as well as difficulty with ascending stairs following prolonged walking. His past medical history was unremarkable, and there was no imaging that had been completed. Just a little background in terms of his athletic participation. In December, he had concluded his football season, and then beginning in January, he had started preseason workouts for soccer. Basically, he was, like I said, a sophomore in high school, and his personal goal was to be able to make the varsity team this year. So he was personally frustrated because he felt like his knee pain was basically impeding upon his ability to fully participate and really show what he was capable of. So again, like I said, the patient was an athlete, and he was very in tune, just like with his own body, and able to identify certain just problems. The ones that he identified were right anterior knee pain, right quadricep weakness, and then just global right hip weakness. So moving forward to my objective exam, just looking at what the research had to say, and basically a patient with knee problems basically said, make sure to look up and down the chain. So looking at trunk involvement, pelvis involvement, hip involvement. So going into my objective exam, I made sure to keep that in the back of my mind as I proceeded. So objective exam. Initially, an active range of motion screen was performed. Again, both right knee and left knee flexion and extension were within normal limits. However, right knee flexion was limited by 4 degrees in comparison to the left. Ankle and foot, as well as bilateral hip active range of motion was assessed. However, it was unremarkable. Gross strength testing was performed, and the right knee flexion and extension was 4+ out of 5 in comparison with the left knee, which was 5 out of 5 at all movements. Right hip gross strength testing was also performed, and this showed 4 out of 5, both abduction and flexion on the right, as well as 4- out of 5 with extension on the right, in comparison to 5 out of 5 with all left hip movements. Ankle and foot gross strength testing was performed, however, it was unremarkable. Again, too, the patient had no pain with any of the gross strength testing. So moving forward, looking at palpation, there was moderate right subpatellar and lateral effusion noted. Crepitus was also noted under the right patella with motion. A complete neural exam was performed, was within normal limits, and the patient denied any numbness and tingling. So as you'll see, a slew of special tests were performed, basically just to make sure that there was no, basically testing the integrity of all the ligaments and making sure there was no involvement there. The patient was positive for a McConnell chondromalacia test, which is basically the patellar grind test with movement, as well as he was positive with the Thomas test, which showed TFL involvement, and then also positive with the hamstring 90-90 test. Looking at joint mobility, he was hypomobile right inferior and medial patellar glides. And the outcome measure that I utilized was the LEFS, so basically the lower extremity functional scale, which is a little recap there, and basically looks at the patient's ability to perform just daily activities, recreational activities, standing, sitting, going squatting, stair climbing, running, and basically they identify, how much difficulty they have with that activity. So if the patient scores like a 4 for that activity, that's the most they would get. 0 is complete inability to perform. So initially the patient scored a 70 out of 80 on his LEFS, which is actually pretty good to start out. So breaking it down, using the ICF framework, the health condition identified was right patellar tendonitis. The impairments noted, which these are in no particular order, but this was decreased right hip flexor strength, abductor strength, and extensor strength, as well as decreased right patellar tracking, restricted right knee medial and inferior glides, decreased right hamstring flexibility, decreased right TFL flexibility, right patellofemoral pain, and decreased right quadricep strength. The activities that he participated in were playing soccer, playing football, attending school, climbing stairs, as well as running. His participation included being a soccer player, a football player, runner, school attender, and stair climber. His environment included that of being at home, school, soccer field, and football field. And lastly, the personal factors included being a 15-year-old male, a sophomore in high school, son, brother, teammate, student, athlete, and he was personally motivated. So moving kind of transitioning from the objective exam into more of the intervention and dysfunctional analysis, identified some of the potential hypotheses that might help me to then conclude a primary impairment. These hypotheses included the patient's running limitations may be related to decreased right hip strength resulting in biomechanical changes at the knee. Also, patient's pain and difficulty with squatting may be related to hypermobile right medial and inferior patellar glides. The patient's pain with stair climbing may be related to hypomobile right medial and inferior patellar glides. Also, patient's pain and difficulty with squatting may be related to decreased right hip strength, resulting in biomechanical changes at the knee. And then lastly, patient's running limitations may be related to right anterior knee pain. So from that, I deduced that the primary impairment was patient's running limitations may be related to decreased right hip strength, resulting in biomechanical changes at the knee. The associated diagnosis was that of right knee patellar tendonitis. His prognosis was excellent with return to sport. He personally, like I said, was very motivated. He also had a lot of family support, and seeing where kind of he already was functionally at, his return to sport was good. Plan that I devised was that 2 times per week for 3 weeks, which was totaling 6 visits initially. So what does the research say? Basically, when looking at an individual with these types of impairments coming in, they say that someone specifically to with patellofemoral pain, often it limits both their sports and activity participation for recreational athletes, and common symptoms that are reported are basically difficulty with stairs as well as squats, which were both reported by my patient, and then additionally standing to sit and also prolonged sit. So at the moving towards more of the intervention and functional assessment, that kind of went in conjunction. So having him perform some exercises and then also just looking functionally at other problems that we could address. So initially I had him perform 10 minutes on the elliptical, again with no pain. We then progressed to stretching, and then from there went into more strengthening aspect. So looking at his ability to do sidestepping against resistance, as well as the picture there kind of shows him doing step-ups where the right leg, we're working on that quad activation, also kind of assessing biomechanical changes, both at the hip and the knee as he completed the exercise. And at this visit, the HEP was administered. So initially, that just included stretches. So that was stretching for the hamstring, TFL, and also calf. So moving into the first follow-up, the exercises from the initial evaluation were continued. The reproducible sign that I utilized was squats. So he had identified that squats was a painful activity for him. So he'd come in, he'd perform the squat, typically about 6 to 7 out of 10 pain. We then utilize manual techniques such as the medial and inferior patellar glides, and then he would perform the squat again. Typically his pain reduced to about a 3 to 4 out of 10 following the manual technique. Also at this visit, I implemented wall squats. Again, the dosing with the exercises was just based off of basically patient tolerance and when fatigue was noted, or compensations that had been identified as well. So at this visit, I went ahead and introduced Swiss ball exercise. You might ask why I progressed him that quickly, but like I said, he was an athlete, in tune with his body, able to perform a TA contraction right off the bat, and also TA contraction with bridges. So that's why too, seeing that he was 15 years old, athlete, wanted to keep him engaged, keep things challenging, went ahead and utilized the Swiss ball. And initially, he needed a lot of verbal and tactile cueing in order to perform it correctly. However, with time, that obviously progressed. And so, again, just based off of the manual therapy that I utilized, research has shown that this has a positive effect on reducing pain in patellar tendinopathy patients in both the short and long term. So moving towards my second follow-up, again, like I said, the primary impairment that I had identified was that of global or decreased global right hip strength. So really making sure to hone into the strength aspect. So whether that was having him do the resisted sidestepping, the step-ups, clamshells, and then also at this one, I introduced standing hip extension. And in conglomeration with the squatting, I also used the use of the treadmill to kind of monitor how we were doing and how he was progressing in terms of his pain and just able to participate in more sport-like activities. So every time he came into the clinic, he would notify that he had no pain. His pain was specifically with certain activity participation, and that was always running, squatting, or stair climbing, so more about weight-bearing type activity. So he would come in, I had him do 2 minutes of walking warm-up, and then he ran for 6 minutes during this visit. The time in which he ran was based off of pain initiation, so I had him cease running once pain began. So at his third follow-up visit, again, the exercises from the previous visits were continued. Also at this one, I went ahead and introduced approximately 3 new Swiss ball exercises. These included like the one in the picture, basically doing the bridge there with his back supported on the ball. And then we also added leg lifts with that same type of activity. And then also had him do leg lifts from the hip, like bridging type sequence that was on the mat. So again, this was based off of his personal fatigue. Often to start, he was very shaky. You commonly saw some kind of like pelvic drop, as well as he had difficulty maintaining that hip abduction and extension. So provided with a lot of tactile cueing, and also at this visit had him get back on the treadmill and performed the 1 minute of walking warm up. And then at this visit, he was able to run for 9.5 minutes before pain initiation. So you'll see with each follow-up, he typically added about 3 minutes of running each treatment session that he came in. So we were progressing in the right direction, which was encouraging. Also during this visit, I went ahead and updated his home exercise program. His mother owned a Swiss ball, so we were able to incorporate that at home, giving him the extra time and just to perform those exercises. And then when he come into the clinic, could really kind of hone those and then continue to build that strength and stuff like that. So let's see, and he demonstrated excellent compliance with his HEP. Every day he would do it, and even on days where he had therapy. So like I said, very personally motivated, taking kind of ownership of his own plan of care and wanting to progress and really be done with therapy as soon as he could, because he was a young guy and wanted to get back into his school of activities and not be having to miss practice in order to come in for therapy. Something too that I wanted to go ahead and at the beginning, there was a lot of patient education regarding kind of that balance of pushing through the pain, what was too much, what was not enough. And we kind of talked and I know he wanted to continue with his soccer practices. And like I said, there was only a few activities that really provoked the pain. So to most extent, he could participate in his soccer practice without pain. It was more the running when they had to do endurance, whether it's 2 miles of consecutive running or certain squatting activities and whatnot. And so I told him that, it's fine to continue on with your soccer practice, but if your pain reaches greater than about a 3 out of 10, I need you to cease activity, kind of let that calm down. And then once your pain is subsided, then you can begin to participate again. Because his natural go-to was to kind of just push through it. So kind of training him and educating him on the importance of not doing that. As well as, I believe it was during his second follow-up visit, I also educated him on how to complete those patellar glides independently at home. That way, when he was at practice, if he had pain, he could take a minute, sit out, perform the glides, see if it helped his pain ratings, and then continue to get back into his activity. So again, why did I use the Swiss ball? Research has shown that basically in this particular study too, it was studied to use soccer players, and it showed that the core strength training, which with some of those exercises we had also identified as being a deficit, it helped to utilize basically an unstable surface rather than a stable surface in order to increase that in the patient. And then this in turn helped basically with the trunk muscle strength as well as sprinting ability and kicking performance was also improved when using the unstable surface rather than the stable surface. Again, this study also showed that using a Swiss ball rather than exercises on a mat was more beneficial for the patient in the long term. So his fourth follow-up visit. At this visit, the patient reported he was about 50% back to normal, and we continued with the previous exercises that have been utilized. At this visit, he was also able to complete the 1-minute walking warm-up and then proceed into 12 and a half minutes of running at 5.5 miles per hour. So again, following that good progression, kind of like a 3-minute addition each time. At the fifth follow-up, we went ahead and performed a reeval. At this time, the patient identified that his pain, rather than being a 6 or 7 out of 10, was now down to a 3 or 4 at its worst. He also said he was able to run 2 miles consistently at soccer practice. However, this was with about 2 to 3 out of 10 pain, so it wasn't complete pain-free. Also, the gross strength testing showed that both knee and hip was 5 out of 5 bilaterally, all movements. Patellar mobilizations were now unrestricted, and the NCID was achieved for the LAFS. It was now 76 out of 80. So at this time, I devised that his max potential for sports participation had still not been achieved, and so I went ahead and extended his plan of care by 6 additional visits. Again, at this visit, he was able to increase the amount of weight with the standing hip extension, and the treadmill running, he was able to reach 16 minutes prior to pain initiation. At his 6th follow-up visit, again, now you'll see here with the treadmill running, it did decrease back down to the 12 and a half. However, this was due to right shin pain. The right shin pain was not reproducible. It was something that was just kind of localized to this treatment session. After he stepped off the treadmill, he did a few stretches and then his pain resolved. This wasn't something that he had been struggling with at practice or any of the treatment visits to follow. So it was something we monitored, but it didn't come back up. Again, we were able to progress him with his wall squats, now using a Bosu ball with the ball down, just again to further challenge him and work on both the really the strength and stability aspects. At this visit, the patient notified that he was about 90% back to normal. He felt like he was ready to basically conclude his therapy services. He had, as school had picked up and his practices were now more like consistent basis, and he wasn't wanting to have to pull out of school or therapy in order to, school or practice in order to come to therapy. And he felt like he could go ahead and just continue with his HEP at home. And I trusted him with that because he'd been very compliant thus far. So at this point, we decided we would go ahead and prepare for discharge. And so at his 7th follow-up, this was his DC visit, he verbalized that he no longer had any activity restrictions. And he said he hadn't had any right knee pain with the running during soccer practice. He also was really excited because he'd had tryouts that week and he made the varsity soccer team. So for him, his personal goal had been met and he was pumped and ready to go. And he had continued with his HEP compliance. Again, this was a shortened session, just he had come kind of during the middle of his school day, and we didn't perform the treadmill running because he didn't want to go back to school all sweaty. So we also looked at his range of motion, and now he had 145 degrees of flexion bilaterally. His gross strength testing for both hips and knees were 5 out of 5 all motions. Now all the special tests were negative bilaterally, and his patellar glides were unrestricted as well. Again, having him fill out the LAFS, he had now reached an 80 out of 80, so perfect score, and had met all of his short and long-term goals as well as his personal goals. So in retrospect, what would I have done differently? Again, if I had had additional time with this patient as well, seeing that he basically self-discharged, these are just some things that I would have taken into consideration. So basically, one, I could have performed a treadmill running analysis. We had used more of the treadmill kind of as a pain gauge and just how much he was able to participate without the pain. However, I could have looked more at his specific biomechanics, whether we needed to adjust, heel strike, toe off, just the biomechanics in general with the running. Also, research has shown that the use of single leg squat implementation can be helpful. Basically, just helping the patient to identify. So specifically, when research has said that when there's issues at the knee, you commonly see it's adduction, internal rotation, and at the hip, which kind of creates more of a genu valgus, which is something that I had noticed in the patient. So having him do more of that single leg activity would really hone in then on the need to strengthen those external rotators, extensors, and abductors at the hip, and just making the patient very mentally aware and honing in on those areas specifically. Also, if I had had more time with him, we could have progressed him to more agility tasks, seeing that he was a multi-sport athlete. Additionally, I could have utilized the concept of eccentric quadriceps training on the decline board. So this has been shown that rehab like this, it allows a graduated increase in the load applied to the knee, and then it also encourages results in terms of pain reduction and just return to function in the short term. So again, I know just something to kind of highlight here, you might say, well, how did he have strength gains when he'd only been coming for about 7-8 visits? That's a short time to get those gains. However, wanted to clarify in that regard, because you might think, well, really that's only about 4 weeks worth, but really he was coming for approximately 6.5 weeks. He started his care January 4th, and he concluded his care, I believe it was February 17th. And so in the midst there had been a few times when he had to call in and cancel just due to school activities or sporting activities that came up, or mom had something come up at work and wasn't going to be able to come and get him and then bring him in, seeing that he wasn't licensed to drive. So the care itself was more over a 6 to 6.5 week time frame. Therefore, that's how the strength, increase in strength was able to occur, basically. So here's my references, and any questions?
What did you see in your initial eval that, I guess, warranted all of the core strength training?
Sure, yeah. So having him, so when we looked at, I'm gonna go back to that slide. So really the core stuff wasn't something that was identified in so much initially. It was more progressing into the second visit when I introduced some of those Swiss ball activities and kind of what we were seeing there, more just of an ongoing functional assessment. Like I said, the strength was something that was really identified from day one, and then moving throughout was able to address some of the core stability and more moving in that regard, and just like endurance in general.
Yeah, I'll ask what will seem like a ridiculous question. How confident are you that his strength?
I'm fairly confident. I know initially you think 4 minus isn't that far away from a 5, but at the same time, the way that he was graded, that right leg was graded in comparison to the left, kind of using that left as that baseline. And by the end, the fact that he was able to perform these exercises, one, correctly, not really needing any more verbal cueing or tactile cueing, and the lack of compensation that was made, and being able to perform the exercise fluidly and without muscular distress. And so there was definite strength gains.
So one thing to suggest is that when you're doing a presentation such as this, and there are just minor, anything above a 3+, right, it's the reliability, validity is not good. So you could have done a functional assessment of strength. So even as simple as how many straight leg raises can do, and that would make your argument stronger that he actually increased strength.
Absolutely.
I like the fact that you went to exercise. My other question is about the diagnosis.
Okay.
What led you to make that diagnosis, or
Sure.
come with it?
So more with the functional assessment, noting particularly one that the activities that he noted were difficult for him, just the functional limitations in terms of the stair climbing, the running, the squatting. Also the pain that was involved regarding that, and we're just kind of taking his subjective information and kind of piecing that together.
How did you end up with tendinitis from that?
Well, he also had the this is something that I wanted to include, but I know I kind of identified the edema that was noted around the knee, And that was something that I wish I would have used a tape measure initially to like quantify. That's something that I would do, differently in retrospect. But so basically in terms of like the inflammation that was present, the pain that was identified, the functional limitations that were there, and just like the decreased patellar tracking with that squatting motion.
So I'm gonna push a little further. Decreased patellar tracking.
The smoothness of the motion in comparison to the left.
So let me just end with this one thing. The likelihood of him having tendonitis, tendinosis, without hemophysician testing, unless I missed that.
No, he didn't. It was very subject to the
So that would
activity.
be, something to really consider, because it might have even just been safe for calling it patellofemoral pain syndrome.
Okay.
Because when you're focusing on that tendon, you think tendinosis, you're gonna have pain with resistant testing of some sort. So, just a generalization. That direction.
No, thank you.
Did you contemplate any manual techniques when it came to management of this condition?
So you saying other than the patellar glides?
Yeah.
We utilize that, and then also just a little bit of like soft tissue mobilization along the way, but no other manual technique.
How does knee look in terms of some of the accessory motion? Did you have a chance to assess that?
Can you clarify that,
Like-
please?
The way his knee like gliding, just within the
Like tibia on femur instead of just.
maybe. Go ahead, what you say.
I said like tibia on femur
Yeah.
instead of just patella.
No, that wasn't something that I directly assessed, but excellent looking at that. And like I said, with the patellar tracking aspect, that was something that was more looked at functionally. So like when he would do his squats, just kind of watching, like I was telling Dr. Kirkman, the smoothness of the tracking in comparison to the left knee. But regarding the accessory motion, not as specific.
Well, just I was going to do.
No, go ahead.
What about, did he ask about taping or bracing or any of those kinds of things? We always want to wear a brace. Oh, yeah.
That's
My kid plays soccer. They don't.
That wasn't something that the patient identified. We did verbalize that to him and say this was an option. We could try this. He wasn't interested. He didn't feel like it would help. He kind of already had like semi-mental block towards that. So seeing that wasn't really one of his patient values, thinking it would be effective, that's why we went ahead and didn't utilize it. Seeing that he kind of had already put that out of his mind, so I was gonna have to kind of convince him otherwise of give it a shot, so that's why I didn't.
That was her question.
Let her know. I don't have.